Welcome again, everyone, for joining us for today's Ask the Ataxia Expert session. I'm Lori Sjogren, the Program Director here at the National Ataxia Foundation, and I'll be assisting with today's session along with a few of my colleagues. Before we get started, I just wanted to note that closed captioning is available for today's session. And if you need closed captioning, in order to enable the closed captioning, you click on the closed captioning button. That's found at the bottom of your screen, and then you select the show subtitles option. Also, questions for our expert can be typed in the chat at any time. To open the chat window, you click on the chat button. That's also found at the bottom of your screen, and we'll try to answer as many of your questions as time allows. We do have a hard stop at the top of the hour, and so we'll be respectful of Dr. Susan Perlman's time and answer as many of your questions as time allows within our hour today. So we're so grateful to have the incredible Dr. Susan Perlman as our expert again today. Dr. Perlman is currently a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you so much, Lori, for inviting me again. And I'm just trying out your closed caption option there. And it's kind of like on TV where it transcribes a third of what you said and misspells most of it, but hopefully it will work, you know, for people that want to use that option. So I was looking through some of the questions that have already come in, and had an opportunity prior to the session to look up some information about some earlier questions that had been given to me. So one of the first ones here is from Mark. What has been the experience of patients who have received any of the psychedelic drugs? And so you wonder, what psychedelic drugs are we talking about? Are we going back to LSD? Are we talking about, some medical marijuana? And then the second question was, does it improve the quality of their lives with ataxia? So it's an interesting question. Classical use of psychedelic drugs is to escape reality, and it's not clear that escaping reality is going to help ataxia, where you have to be more aware of your environment and what you're doing. However, use of cannabis or medical marijuana is very common. It's used and been found to be helpful for pain. It's been found to be helpful for sleep problems, both of which can be issues for the ataxic patient. But will it actually improve ataxia? So we had gotten another question about, can ataxia be acquired from cannabis abuse rather than alcohol abuse that we know can target the cerebellum? So the general feeling is that acute cannabis intoxication is like alcohol, that it impairs balance, coordination, it impairs vision. And it's probably not a good idea unless you're planning to stay in for several hours until it wears off. However, ongoing moderate use has been associated with some issues. And I found a few articles that have explored this. There are studies that suggest that long-term or heavy use of cannabis can impair memory, can cause psychiatric issues over a long period of time, contributing to depression, anxiety, psychosis even, or apathy, and that long-term use of moderate to high dose cannabis is not encouraged, but occasional use of therapeutic amounts for sleep assistance or for controlling pain can be a helpful alternative. Another question that came in early was gluten ataxia. Question of, should I see a specialist, and what type of specialist, someone who's been diagnosed with gluten ataxia? Should they see an ataxia neurologist, an immunologist, a neuroimmunologist, or someone else? So with a diagnosed gluten ataxia, the only reliable approach is a very strict gluten-free diet. And then anti-immune therapies as appropriate. So I think certainly an ataxia neurologist would be able to give good guidance. A dietitian or a nutritionist can help somebody plan a very strict gluten-free diet that is still a healthful diet. And I often will refer to our neuroimmunology group here when I have a question about an autoimmune ataxia and choosing an immune therapy. So I think they're all good options, and information can probably enhance getting opinions from a couple of them. Another question came in about a recent publication about the use of granulocyte colony stimulating factor injections, they're subcutaneous injections, to increase frataxin protein level and potentially improve the symptoms of Friedreich's ataxia. Now, this is a study that's been going on for a while in Great Britain, and there was a recent publication of their open label pilot study looking at what they were able to show with the effect of this injection on stimulating the production and release of white blood cells. And it appears that occurs by stimulation of certain growth factors or other factors that have a kind of a side benefit on the production of frataxin protein. It seems that by using this granulocyte colony stimulating factor, which is normally used in people with low white cell counts, that you can increase the levels of regulatory pathways, PGC1 alpha and NRF2, which we all know in Friedreich's ataxia has been a pathway that has been targeted by the Reata drug omaveloxolone, that the NRF2 pathway is underactive, seems to contribute to mitochondrial dysfunction, and by activating it, you can ostensibly improve mitochondrial function and symptoms of Friedreich's ataxia. So technically, by these injections of granulocyte colony stimulating factor, you can stimulate that pathway. You can stimulate other pathways that might have a benefit in increasing frataxin protein production and hopefully the clinical symptoms of Friedreich's. The downside of this treatment is that when it's used to treat people with low white cell count, it's given, for short periods of time, 5 days in a row, daily injections, or upwards of, 3 weeks. But for ongoing use in a condition like Friedreich's, there's the risk of ongoing side effects that may not have been described yet because its technical use is typically in hospital or with patients who will use it intermittently to boost their white cell count. So I know of one Friedreich's ataxia patient who was getting it from his local physician. I don't know if he felt any benefits from it, and I don't know if he continued it over a long term. But off-label use of any drug that appears to be entering the pipeline for any of the ataxias, but hasn't been fully examined for long-term side effects and the true potential for benefit, should really be looked at with a lot of caution and a lot of advice. Then one of the other questions that came through, again about a scientific publication, was it was found that one of the HIV medications might be used to treat ataxia telangiectasia. And we know that one of the HIV medications is currently in trials in Italy for Friedreich's ataxia, apparently having some impact on frataxin protein levels. So this other HIV medication that was part of this study, which included patients, included an animal model of ataxia telangiectasia, was looking at the hyperactivity of a particular genetic factor that when it was hyperactive, it could contribute to damage to the cerebellar nerve cells. And this particular HIV medication could block or reduce the hyperactivity of this particular genetic factor. So it's interesting because this particular genetic factor is involved in DNA repair. When it's hyperactive, it can actually damage DNA. And in ataxia telangiectasia, that is one of the things that occurs in these patients. There is DNA damage. So targeting ataxia telangiectasia with something that might block that damaging effect and block the damaging effect on the Purkinje cells in the cerebellum makes a lot of scientific sense, and we may see more about this. They did, however, look for hyperactivity of this particular genetic factor, the line-1 factor, in other forms of ataxia, and they did not find that it was hyperactive. So the use of this particular HIV drug might be restricted just to the ataxia telangiectasia group, just like the etravirine HIV drug is being looked at primarily for Friedreich's ataxia. But you're correct in that many things that come up in basic science may have broader application to all of the ataxic disorders, and we do need to follow those. We do need to follow those. So the next question is from Joe. Diagnosed with ataxia, an unspecified kind after multiple genetic tests, but with a positive family history. And a couple of issues have come up in his management. Number one, his HMO doesn't have an ataxia specialist, although it appears that they've done a good job of genetic testing. And, they are not willing to refer him to an ataxia clinic for further genetic assessment or assessment for symptomatic management, because they say that it would be an unjustified escalation of service that they'd have to pay for. So that they say if he wants an ataxia expert outside of his HMO to see him, then he's going to have to pay for it himself. And this is a common problem, that HMOs and the HMO model, which may be infiltrating other insurance plans, is looking at saving money and, keeping things under tight control for the purposes of the bean counters. I know for basic genetic testing, the National Ataxia Foundation has opened up a free genetic testing program for people who can't get the basic genetic testing done through their insurance. But somebody in this situation who may need a more expert opinion may have to, at this point, pay for a consultation himself, and then take those recommendations back to his HMO doctor and see if they'll carry through. One interesting symptom that Joe mentioned, that he is easily startled by unexpected and sudden noises, like the telephone ringing, so that he might spill things. The startle reflex, increased startle reflex, is seen in several of the genetic ataxias, and can be specifically treated with medications like clonazepam to settle it down. And this could be a clue to his HMO doctor that the basic genetic testing, which turned out negative, might need a deeper dive. And I hope he'll express this concern, because the startle reflex as part of ataxic syndromes has been described. Now, from Carla, who's 58 years old with Friedreich's ataxia. She's nearsighted, has nystagmus and eye movement issues that are associated with Friedreich's, but has also developed glaucoma and is under treatment for that. Question number one, is increased eye pressure glaucoma associated with Friedreich's? although there are intrinsic eye issues besides the nystagmus that are seen with Friedreich's. There's some thinning and weakening of the optic nerve, which can make it hard to correct vision with even the best glasses, and vision becomes blurred. And in some patients, they may lose visual acuity and not be able to correct it. This is associated with changes in the optic nerve and changes in the retina, which can be seen on exam. Now, glaucoma, if not treated, can cause changes in the retina as well, and I'm glad that she's under treatment. But I think her glaucoma is a separate problem. But I would hope that with her regular eye exams, they're also monitoring the optic nerve and the retina for changes that could be due to Friedreich's. There's another symptom that Carla has brought up. Muscles, especially in legs and lower back, get very stiff. Worsens under stress and may wake her up in the middle of the night with feelings of stiffness and pain. And she says, is this rigidity, which comes from a certain part of the brain, or is it spasticity, which comes from a different part of the brain? And either one could be treated, but they're treated very differently. So knowing that she has Friedreich's, I would say it's most likely spasticity that is causing the painful spasms and stiffening up. She mentions that it can be treated with muscle relaxers. Now, there are simple muscle relaxers like Soma, Carisoprodol, which is the generic name of that. Flexeril is another one that directly relax the muscle, but can cause muscle weakness. The ones that relax the nerve that goes to the muscle, things like baclofen, tizanidine, can sometimes be used at lower dose so as not to cause weakness, but enough to get rid of some of that episodic stiffness and painful spasms. And certainly it seems now it might be better to use something like that at night. And during the day, rely on stretching and regular exercise to keep those muscles relaxed. Now, from Salil, is there any evidence that SCA, spinocerebellar ataxia-related symptoms, could have gotten worse during COVID? I noticed that change in my symptoms. So during the acute phase of COVID, with the acute infection, whatever symptoms one has, almost any neurologic symptom could get worse. Migraine headaches could get worse if you had them before. And symptoms of ataxia could certainly get worse with the COVID infection or with any infection or febrile illness. Ideally, after the illness has passed, those ataxia symptoms should go back to their baseline. Sometimes it can take a week or two with a slightly delayed recovery. However, there is a concern that some people experiencing COVID can develop what's called long COVID, an ongoing immune reaction to the prior infection, which can contribute to fatigability, muscle aches that could complicate an ataxia picture. So if somebody had COVID and had some worsening of their ataxia symptoms or some other symptoms that are not resolving after a couple of weeks, they should certainly seek medical advice about the possibility of long COVID, which is under research right now. And this individual, Salil, also mentioned symptomatic treatment, taking, for ataxia, causing collateral damage. And I'm hoping that that's just collateral side effects, from the drug. Many of the drugs that are used for managing symptoms of ataxia have a long list of potential side effects. Stopping medication is obviously the way to see if that is the cause. Salil mentions they stopped all medications with no worsening of their spinocerebellar ataxia type 12 symptoms. All the side effects were reversed, and that is what we would hope to see. Obviously, we would hope that a symptomatic drug would help the ataxia without side effects, but it's something that we have to be alert to. And again, experiencing numbness and cold sensations in the toes, is that attributable to SCA, or could there be other reasons? Certainly, as we get older, we could develop circulatory problems. They could give us, coldness and problems with circulation in the legs, in the feet and toes. Some ataxias that affect peripheral nerves, in addition to the balance center, can cause numbness, tingling, twitching, or coldness in distal extremities, feet and hands. So this is possibly part of the SCA12 syndrome, but it's important that your medical doctor be aware of something that isn't obviously ataxia in case there's another medical cause for it. Okay, question from Danielle. Does TDCS, transcranial direct current stimulation, help people with ataxia? And I think the same question could be asked about transcranial magnetic stimulation, putting magnets or electrodes on the head to stimulate balance-related pathways. There is research going on with both of these modalities, and there is some evidence that they can help reprogram motor pathways to compensate for ataxia. Currently, neither modality is approved for ataxia, although transcranial magnetic stimulation is approved for the treatment of depression. And so this is an area that deserves watching, since when we talk about symptomatic management, we're usually thinking of pills or medications that medicate the whole body. This is something that could potentially be targeted, the way physical therapy can be targeted to the actual ataxia-related pathways. Now, Matthew has a question. I'm wondering if you have any insights about the supplement 7,8-dihydroxyflavone. Came across a study from McGill University that it can improve motor coordination and Purkinje cell firing rate in SCA6. And fortunately, they've given us a link to that study, because I am unfamiliar with that agent and I'm unfamiliar with that study. So activating the link, I find that it was working in a mouse model of ataxia type 6. And this particular agent that was being used seems to act on levels of cerebellar brain-derived neurotrophic factor. So again, it's a neurotrophic factor, and its receptor. It seems to activate the receptor, increasing levels of brain-derived neurotrophic factor, which can then protect the cerebellar neurons or allow them to work better. So it's indicated as a promising therapy, but given that this published study was just in the mouse and not yet in people, and it was literally just published a few days ago, you would want to see, is this an agent that could be safely used in patients? Is there a dose that would potentially work in patients as opposed to in mice? Will you be able to get enough into the brain? So we definitely should look more closely at this, and I will try to remember to follow this a little more closely in the literature for my own active curiosity as well. So I'm going to save that. Okay. Here's one from Luis Carlos. With ataxia unknown without a family history, using ubiquinol 200 milligrams, which is the active form of CoQ10, better absorbed than regular CoQ10, so it can be used at about half the dose of regular CoQ10. Regular CoQ10, for its neuroprotective antioxidant capabilities, anti-aging capabilities, is normally looked at in doses upwards of 1,200 milligrams per day. There was a study looking at it in doses of 2,400 milligrams per day in Parkinson's disease, but much above 1,200 milligrams per day, you're just not absorbing anymore. So I would say, a dose of regular CoQ10 between 400 and 1200 milligrams per day would be a reasonable one to start with. And the ubiquinol dose would be, half of that. So it would be 200 to 600 milligrams per day. And if you're going to be working with a nutraceutical or something, a supplement like ubiquinol or CoQ10, usually recommend using it for a couple of months to see if you notice any side effects or any potential benefits, improved fatigability or improved other symptoms. And if you're not noticing, a benefit and you're on a lower dose, you can go to a slightly higher dose. But, if you really feel it is not helping, then, it's, I would, stop it, wait, a few weeks till it leaves your system and then move on to something else that could be of benefit. And there was a second question from Luis about the use of non-invasive stimulation techniques. And they also mentioned transcutaneous stimulation and various techniques that can be used there on muscle and nerve pathways. Certainly, transcutaneous nerve stimulation or muscle stimulation can be used to help muscle spasms, muscle pain, peripheral pain from other causes, but it's not clear that the peripheral use is going to benefit ataxia, while the two central ones that we mentioned before are in active research for ataxia. So, will children be part of the second round extension study of omaveloxolone? This is from Elise. Now, I know there's been a lot of talk over the last few months about the upcoming FDA review of OMAV and its ability to activate the NRF2 pathway that we mentioned before, which can improve mitochondrial function and the ability of mitochondria to fight free radical stress. The current OMAV study that was presented to the FDA and is under examination by them only went down to age 16. And if it's a safe drug, which if it appears to be safe, you would want to use it potentially in younger individuals, but you'd have to do safety testing, not necessarily testing for benefits, but at least demonstrate to the FDA that it's safe to use in children under the age of 16. And then, they would also have an opportunity to try it to look for benefits as well. We hope that Reata will be doing a safety study, a safety and dosing study in children under the age of 16, but they haven't yet committed to that. So we'll just have to wait and see, what they continue to advise us. What is the status of the clinical trial from Biogen? This is from EFRAT. The Biogen study of using antisense moiety injections into the spinal fluid to block the production of the mutant protein in spinocerebellar ataxia type 3. And this is a technology that's been used to block the production of the mutant protein in Huntington's disease. The antisense injections into the spinal fluid has been used in spinal muscular atrophy to modify the progression of that devastating infantile disease. So the technology has been out there, it has been in use. The trial has been designed and has been opened up at several sites now under Biogen for spinocerebellar ataxia type 3. It is a dose-finding trial. It's a phase 1 trial where they're starting with group 1, which is the lowest dose given on a monthly basis for 4 months. The next group of 8 patients is going to have a low medium dose and then gradually increasing doses. So they are recruiting for this study. It's a 4-month commitment for the injections and then follow up for the next 8 months to see how you do afterwards. So it's, I think, an important study. It's the first of its kind in ataxia, the first of the gene targeting therapies in ataxia. So we'll see how enrollment goes, and hopefully there won't be any unexpected side effects that is going to alter its progress. Yun Lee has a question about CoQ10 and vitamin E. Are they helpful to SCA3 in its early stages? Vitamin E has been known to be symptomatically helpful for muscle cramps and spasms. CoQ10 has been known to be symptomatically beneficial for fatigue. Are they neuroprotective? Studies of CoQ10 and vitamin E in other neurogenetic disorders, Friedreich's ataxia, did not show any symptomatic benefit, but suggested that it might slow progression. And this was a study that was done many years ago. A similar study was done in Huntington's disease, and it just didn't seem to be helpful in slowing progression. So I think for short-term symptomatic management of fatigue or nerve or muscle pain, they could certainly be tried. But as anti-aging or neuroprotective agents to slow progression of genetic ataxia, they haven't really shown that benefit. If we look at the anti-aging literature, things that are purported to help the brain age more gracefully, certainly, modest doses of vitamin E, CoQ10 is in the literature, omega fish oil is in the literature, and other agents as well. So if you want to try something from the nutritional side, a vitamin or a supplement, again, choose a sensible dose, not a mega dose. Try it for 2 to 3 months, see how you feel. If you feel there have been benefits, continue it. If you don't feel there have been benefits, then stop it and move on. And certainly Rob Baker's question, are over-the-counter brain supplements helpful? And certainly there's been a lot in the news about supplements to help Alzheimer's disease or dementia. There are competing, groups that are making a variety of interesting supplements, one of which is Prevagen, which has been in the literature and the popular media for a while. But there, now are concerns about long-term side effects using Prevagen. So again, for short-term use, it's, if you can find enough information about safety and it's not going to interact with other medications you might be taking, you can try them for the short term. If you feel they're beneficial, then look into the literature about long-term risks of using any nutritional supplement, herbal supplement. They can interact with other medications, and they can have long-term side effects, on the liver, for instance. So is ataxia considered a neuromuscular disease? This is from Stephanie. Friedreich's ataxia is part of the Muscular Dystrophy Association neuromuscular disease clinic diagnoses. Other ataxias, the prominent changes are more in the brain and not in the peripheral neuromuscular system. Although some of the dominantly inherited ataxias and some of the recessive ataxias, like Friedreich's, may involve peripheral nerve and muscle pathways. So could an ataxia patient go to a neuromuscular specialist and receive a correct diagnosis? I would say yes. Neuromuscular specialists, even though they may specialize in muscle diseases, are familiar with all of the genetic disorders that could potentially affect the neuromuscular system. They may not be as familiar with treatment of ataxia, but I think they could certainly assist in a proper diagnosis. And then a second question, do ataxia patients have a weak or absent cough that can lead to upper respiratory infections? Certainly, breathing requires coordination. Many ataxia patients will have altered breathing at night. They'll have obstructive sleep apnea or other changes in breathing rhythm at night. And they may find that talking and breathing and eating are competing things, that if you have to coordinate eating and swallowing, it's going to be hard, to coordinate breathing at the same time. And the same thing with breathing and speaking, you have to coordinate breathing in order to coordinate your speaking. So, there's definitely a role of breathing and, the cough reflex in patients with ataxia. Certainly, if you can't cough, if something gets lodged in your throat or is on its way into your airways, it could lead to a pneumonia or an upper respiratory infection. And it's important to be alert to, if you're beginning to have feelings of a weak cough, trouble clearing your throat, to have that assessed by pulmonary or by your ataxia neurologist and then pulmonary, to make sure that you're not at risk for developing an aspiration pneumonia. And does ataxia affect the pons? The pons is the middle part of the brainstem, and signals coming into the cerebellum enter it from the area below the pons typically, but they can also enter it from pathways that cross the pons. And similarly, output from the cerebellum, those outgoing fibers, some of them go above the pons, but some of them interact with the pons. So that some ataxias have thinning or shrinkage of the pons in addition to the cerebellum, just because the signals are weakened and the pons becomes smaller and may have scar tissue in it. There are some ataxias where the pons is directly attacked by whatever the cause of the ataxia is. And our knowledge, from the work done in the genetic ataxias, we can pretty much identify forms of ataxia where we expect the pons to be involved, and others where, if the pons became weak at any point, it would be after many years of illness. Then a long question, again from Brazil, from Marcio. His wife has spinocerebellar ataxia type 3, asking about the current therapy trials that are running. Mentions the troriluzole study from Biohaven, which is wrapping up, and hopefully will be ready to submit to the FDA as a potential neuroprotective agent, but also a symptomatic agent to stimulate better coordination and balance. The two studies that are just beginning are more disease modifying and may not have immediate symptomatic benefit. One is the trehalose, which is a disaccharide. It's a form of sugar that, given intravenously, and there was a study several years ago investigating that in a small group of patients, seems to be able to break up the bad protein that was accumulating in the nerves in spinocerebellar ataxia type 3. So now that's moving forward into a larger study here in the United States to see if, as a protein busting drug, as it were, it can slow progression of ataxia and potentially allow nerves to heal. And they're specifically looking at SCA3, although it could possibly work for some of the other SCAs as well. And then the Biogen study that we've already talked about. Now, Marcio brings up that there's an oral trehalose study going on in Malaysia, where they feel that giving the sugar at a proper dose by mouth, you can get enough absorbed into the brain to break up the bad protein. If you look at the amount of trehalose they're having people take in that study, it is a huge amount, a half a cup of it. And, you have to take it, technically all at once so that you can overload your GI tract and get enough absorbed that some will get to the brain, because otherwise it just gets digested like regular sugar would get digested. And I had one patient who tried that at the Malaysian dose, and it was so upsetting to her stomach that she felt she really couldn't continue that. So I think if we're going to look at trehalose as something that can help us break down the accumulation of the abnormal protein, it's probably going to have to be given intravenously to bypass the stomach and digestive processes. Christy has a question. How do you find out what type of ataxia you have? First of all, you visit a physician, a neurologist, a geneticist, tell them you have ataxia, let them review the type of symptoms you're having and your family history so that they can decide this must be a recessive ataxia, this is probably a dominant ataxia, this is an X-linked ataxia, which can then guide them to the specific genetic test that will make the diagnosis of the actual type of ataxia. If somebody in your family has already had genetic testing and confirmed that there's ataxia, spinocerebellar ataxia type 3 in the family, and all of a sudden you're having balance problems, and you know that this is the ataxia that runs in your family, many clinicians will accept that as evidence that you too have spinocerebellar ataxia type 3, for instance. However, there are so many other things that can interfere with balance that are not genetic and may be related to something totally, acquired that could be treated very differently, that I think it's important to confirm with a genetic test to make sure that you indeed have that gene and you don't have something, much simpler like a vitamin deficiency. Okay, so we already talked about troriluzole, a question here. Ketones and ataxia, and this is regarding the use of a ketogenic diet like the Atkins diet. Is it helpful? A couple of things might indicate that people who are on the Atkins diet or a ketogenic diet, seem to feel better or do better. We know that simple sugars and simple carbohydrates can increase fatigue, and fatigue will make ataxia symptoms more noticeable. So, the side benefit of avoiding carbs on the ketogenic diet is that you'll be avoiding that complication. Now, for people whose ataxia is caused by a problem in mitochondrial function, oxidative metabolism, they can't use carbohydrates to burn in the mitochondria to make energy. Friedreich's ataxia is one example, but there are others, where the mitochondria are involved, the mitochondria are dysfunctional, adding to the ataxia problem. There's been a thought that you can burn ketones, that if you generate ketones from fat, that you can actually burn those for energy by a different pathway that doesn't totally require the mitochondria involvement. So if somebody wants to try a ketogenic diet, I mean, it's, again, it has to be strict, like the gluten-free diet, it has to be fairly strict. And it can have side effects. People can get dizziness, they can feel weak, they can get hypoglycemic, since the adult brain doesn't really burn ketones as well as the childhood brain does. So the ketogenic diet is used in certain childhood illnesses like childhood epilepsy, but the adult brain may not be able to use ketones as well. Here's a question. Okay, many people are asking about OMAV and about troriluzole, and they're both on the threshold of FDA approval. So we'll be hoping to see some benefits there, for the entire ataxia population, first approved drugs for ataxia. Here's a question of what is the difference of the FSRA and SARA scores? And these are rating scores that are used in a clinic visit with an ataxia neurologist. It's a way to test coordination and balance in a standardized way that from visit to visit, the doctor can tell, oh, that looks a little worse. Oh, and you feel worse. And my exam suggests that it's worse as well. So the regular SARA scale has 8 components. They test walking, they test standing, they test sitting, speech. They test 3 tests of hand coordination and 1 test of leg coordination. So there's 8 components. The FSRA or functional SARA, or the FDA SARA, when you think about it, was encouraged to be developed by the FDA, focusing just on the first 4 components: walking, standing, sitting, and speech, which were felt to be the more reliable and easy to measure parts of the SARA scale. But they eliminate, the ability to assess hand coordination. So the FSRA has been used in ataxia trials, especially if you think it's going to help standing and walking and speech. But if your drug or treatment is supposed to be helping hand coordination, the FSRA will not demonstrate that. So there's still, fortunately, a lot of collaborative work between the FDA, drug companies, and the National Ataxia Foundation at establishing the best ways to measure ataxia. There's some, again, interest in the Moxie trial from Reata with omaveloxolone, and how it went and how the extension phase went, and how promising the data hopefully will be to the FDA in that it did show improvement. It showed stabilization with only slow worsening after a couple of years, much slower than would be expected in somebody who wasn't taking that drug. Buried in that group of patients in that study, I'm sure there were people who did not respond, but it appears that the number of responders was greater than the number of non-responders. And I personally plan, should OMAV be approved, to try it in all of my Friedreich's patients at all stages of the disease within the approved age group, to give them at least 3 months to see if they can begin to get some benefit from it. Dan Caruso has a question about speeding up the unraveling of telomeres so that certain genes will be destroyed. I'm going to have to go back to the literature to check on that. I know that telomeres are involved with aging, that they change with aging, and it's felt that if we can do something to modify telomeres, we can alter aging-related conditions, including some of the ataxias that present as we get older. But I don't have any detailed information about that. What are some ways young adults with ataxia, in this case AOA type 2, can be encouraged to socialize with their peers? This is a tough question. It's a tough question for any parent who is dealing with a teenager or young adult with one of the genetic ataxias, an age where you don't want to be different from your peers, you want to be able to participate with your peers. And a lot of that ability to socialize is going to depend on how receptive the peer group is. I think anyone who is different, whether you're an older adult with a cane, whether you're a young adult with a balance or mobility problem, you're going to stand out. People are going to notice you, and not necessarily in good ways. So a lot of it depends upon educating, the population that, people with varied disabilities, which is not a word that people like to use these days, are absolutely able to participate, to contribute. They have, good personalities, they make good friends, or sometimes they don't make good friends. They're regular people like everybody else. So I think some of it's going to be educating the peer groups, which some of my patients have done. They've given talks in their school about Friedreich's ataxia. They've participated in outreach to the community. They've worked on social media to raise awareness. And I think the National Ataxia Foundation, the Friedreich's Ataxia Research Alliance are very much behind that. Now, if an individual is depressed, worried because of their condition, wanting to just stay in the house and hide, and certainly COVID and remote schooling enabled people to do that. I think that needs to be addressed, by the family, by other adults that, understand the individual, or by a mental health professional if it's felt that there is a significant depression that's holding somebody back. Okay, moving down the list here. Well, here's a comment about medical marijuana. Even the smell of cannabis makes me nauseous. Excellent, William. Good note there. Is levodopa useful for tremors? If you have a tremor that is mediated by the basal ganglia, which are outside the cerebellum but communicate with the cerebellum, and these are typically tremors that occur when your hands aren't doing anything, just sitting in your lap and they're shaking, or a certain tremor when you're trying to reach for something kind of has a rotatory component to it, which means that the basal ganglia is involved in not regulating that properly. Levodopa can absolutely be helpful for tremors of that type. And then different drugs are used for tremors that come from the cerebellum. Peter, is dizziness and or vertigo associated with ataxia? Yes. The cerebellar ataxia, the part from the cerebellum, is often associated with a feeling of disequilibrium, like you're on a boat. And that's because its connections to the central vestibular nuclei, which are part of the cerebellum, are altered. Now, vertigo comes from the peripheral vestibular pathways, the inner ear, and that's more of a spinning sensation. And some people with certain types of ataxia can get peripheral vestibular involvement. Garden variety dizziness could be from peripheral vestibular changes where it's not clearly vertigo, could occur only with head movement, because of involvement of peripheral or central vestibular pathways. But dizziness can also occur from low blood pressure or other circulatory problems. So that, and it could be unrelated to the ataxia. People can get vertigo from Meniere's disease, which is an inner ear problem that has nothing to do with your ataxia, but you're not immune from other conditions. Here's a long question about a patient's brother diagnosed with cerebellar ataxia. Speech and balance have deteriorated over the past 4 years, as have hand coordination. Has been able to manage, but just an overwhelming feeling in the front of his head that makes him lose balance at the slightest movement. So you wonder if that's a central vestibular problem that can appear with head movement or body movement. He finds himself with a blanket over his head a lot to try to avoid that. He's 58. And that sense that he has in the front of his head, number one, isn't seen with all the cerebellar ataxias. I've had several patients with spinocerebellar ataxia type 3 who have described something like that, and patients with other ataxias where we know it's that connection to the central vestibular nuclei that have been altered. It's not as easy to treat as peripheral vestibular changes are, with seasickness medicines, et cetera. But there are physical therapy techniques that can work to coordinate the cerebellum with the central vestibular nuclei that might help get rid of this. Now, I hope because of this odd, heavy feeling in the front of the head that the individual has had a brain MRI scan to rule out something else going on that might be unrelated. For instance, you had a fall, you hit your head, you didn't think much of it, but you could develop an accumulation of blood or fluid over part of the brain, which could give you a headache or, this odd feeling in the head that, could ultimately make your ataxia worse. So important, with any unusual or new symptoms, make sure your imaging is up to date. Do I think going to chiropractic neurologist could be helpful for balance and coordination? It depends what the chiropractic neurologist is doing. If they are doing rapid adjustments of the neck, I think that is a concern because that can affect circulation. They could accidentally damage the nerves or even the spinal cord. But if they're using other chiropractic techniques, craniosacral manipulation and some other things that I know people have done, people have described benefit from it. Symptomatic benefit, it's probably not going to have long-term activity, but I think if you avoid rapid adjustments of the neck or spine in general, that if you want to try it, it's definitely safe. Have I come across cases where COVID-19 vaccine has led to ataxia? No, but I'm sure we can look online and look in the literature and find some cases of a vaccine reaction that has damaged the cerebellum. If you're prone to get a severe allergic reaction to the vaccine, it can result in decreased blood pressure, and you could develop anoxic damage to the cerebellum and cause ataxia. But I'm not aware of any longer term complications from the vaccine leading to ataxia. Here's a question from Brazil: ataxia type 8, spinocerebellar ataxia type 8. There's a pipeline and several pipelines posted on the National Ataxia Foundation website, thanks to Dr. Lauren Moore, detailing for each of the common dominant ataxias and then, Friedreich's ataxia, what the current treatments are in the pipeline. So I recommend going to the National Ataxia Foundation website and looking at the beautiful pipelines that have been posted there. When they say that these are trials available to patients, does that include patients abroad? Some of the trials are only going on outside the United States. Some of the trials going on in the US may take people who are willing to travel. And some companies have sites outside the US and in the US. So to get more detailed information, you should go to clinicaltrials.gov for any of the trials listed on the NAF pipeline. Look up the actual study and see where the sites are located. Here's a question, a support group in South Africa. Apparently there is not one. There's one on Facebook, but not something, where, there's a dedicated group, in South Africa, or a group that meets in person. And if you want to start something like that going, I would contact the group at the National Ataxia Foundation. They have been wonderfully supportive of people who want to start support groups and have a lot of good mentors and ambassadors that can help you do that. Okay, so getting down to the last couple of minutes. Pros and cons of clonazepam for downbeat nystagmus. I think the con is that it can cause drowsiness, which could make your ataxia worse. Does it help oscillopsia or double vision as well? I think one of the side effects of clonazepam besides drowsiness is double vision. So it might not be as helpful for that, but it could certainly be helpful for downbeat nystagmus or potentially oscillopsia, and is worth a try at low dose. Then, a lot of good questions here that I'm not going to be able to get to. Let me do one more. Haley has a question about prism glasses, double vision caused by spinocerebellar ataxia type 3. Getting worried that, was getting used to the prisms, and that they could make things worse, that, you get used to the prisms and then, the eyes become even more, disparate when you take the glasses off. I think one reason prisms may stop working is that your double vision is getting worse because of the ataxia. And at some point, an eye surgery to realign the muscles might be necessary. It's a relatively minor surgery. It seems to be helpful in reducing the double vision so that a lower grade or no prism can be helpful for that period, of time. Again, a lot of good questions, which I'm not going to be able to get to. I have to go back to clinic now, but thank you so much for inviting me. These are fantastic questions, and I hope people, talking amongst themselves and talking with their physicians, can get some clarity as well. And, surf the internet. There's a lot of good information, unfortunately intermixed with some weird stuff, but you can often find answers there as well.
Thank you so much for your time today, Dr. Perlman. You've answered so many good questions that were submitted here by our attendees. Truly appreciate all of your time.
Good. Take care. Bye-bye.
Take care, Dr. Perlman. For everyone else, a recording of today's session will be made available to reference on NAF's website and YouTube channel. And it was so good having you all join us today. I'm also going to pop in a chat a link to our global ataxia support group for those interested in maybe that are outside the US and interested in a support group. They do meet a couple times a month. So recommend anyone outside the US looking for a support group to get involved with and to check them out. And take care everyone until next time.